Terrific. Thank you. Okay, welcome again, everyone here in the audience, and of course those online. Jackie and I are thrilled that you're here, and now we're going to move into what we may refer to as the living room sessions, where we can really engage in some deeper discussions with a group of panelists and experts within their own, in their right. In fact, we have 3 great panels today. One will talk about what I would say real-life experience. The next would talk about policy and regulations, and then the final one will talk about emerging trends and innovations. So it's my honor and thrill to moderate and try to keep this group on point, the panelists and the experts for clinical and scientific use. Now, what does that mean? Right? What is clinical and scientific use? To me, it's about the real-life scenarios that I'd like to hear, and I think we'd all like to ask questions about in everyday life, in treating patients and outcomes. So dosing strategies, perhaps new product formulations, what we're seeing with patients, and really the patient outcome and the therapeutic care. So without further ado, I'd like to have each one of the panelists introduce themselves, take 1 or 2 minutes, talk a little bit about what your role is now, and perhaps what you're seeing in the market. So just a couple minutes, and then we'll get into some questions. So let's start with Dr. Dahmer.
Great. I'll just start out and say thanks to Jackie and Steve and everyone that put this on. You know, again, I think every time we should take a step because it's such a hard thing to do. And so thank you for allowing this opportunity. And I'm Dr. Stephen Dahmer. I'm a family physician. I kind of tend a little bit more towards the holistic and plant realm of things, but also serve and have served as Chief Medical Officer of Vireo Health, also known as Goodness Growth Health, and I've been doing that for 7 years. So 7+ years I've been a part of the cannabis industry, mainly oversaw our retail operations, and we started in Minnesota, a very medical program that, every dispensary, what we call a cannabis patient center, is run by a pharmacist. Every patient sees a pharmacist and has a consultation. And that's kind of how I started into the industry, which has morphed quite a bit to the point where we now are participating in clinical trials and certainly do a lot of educational outreach and a touch of policy. But very excited about the panel and very excited to be here.
Hi, Maureen Fitzpatrick. I'm a nurse practitioner, a family nurse practitioner. I'm probably the least expert person at this table today in the sense that I'm working at the most basic level in the sense of actually evaluating and certifying people in Maryland for medical marijuana. I'm in Baltimore City. My professional life has pretty much always been Baltimore City, so I have a pretty clear perspective in that regard. And I think that's probably as much as I need to say. Yeah.
Maureen, I'm with you on this. I'm Chintu Sharma. I'm an internal medicine and pediatric doc, so I'm just the same family doc everyone else is, just with 2 separate titles. I'm a West Coast-born child that ended up on the East Coast because I married a girl from Montgomery County, Maryland, and you can't escape Maryland if you know Maryland. You cannot escape Maryland if you marry someone from Maryland. So you're here for life, I hate to say it. I work pretty much at the same level Maureen does. I certify folks in my spare time, but my day job is as an administrator for a large health system nearby. So I work as a HM, hospital medicine and critical care director at a hospital that wants to serve a community that needs it really badly. So we're working on developing all sorts of stuff on that side. I do this as a public health outreach because I see a lot of friction in programs. There's so many things we can address on the ground and we can fix as we go as providers. So Maureen, you're doing a great job. But it's one of those where, you have limitations on what you can do in different boxes. So I'm not here to speak on the administrative front, but more as a clinician about the benefits and the things that we need to do and we need to kind of work on as people and as clinicians practicing and as a community of folks that want to drive this forward the right way, which I got to say, that was a great intro. Thanks for that.
Great, thank you. All right, so let's get into it. I think as an entire group here, but certainly as the panel, we all see a need for more evidence-based science and research. We talked about it. We certainly learned about that at the University of Maryland. We need the gold standards. But I think there's such an important thing taking place on the front lines, right, on the ground. And so we have some great experience that I'd like for you to share, perhaps. What are you seeing in your role or in your practice as either emerging trends and patient outcomes that you're seeing? So perhaps, Maureen, you can tell us, what are you seeing in Baltimore City?
There's certainly a lot of variety in the patients I see. I mean, I'm in the city, but because the state of Maryland has changed things to the extent that now I can see patients all over the state through video, makes it a lot easier. But I was interested in hearing some of the comments Dr. Tischler had, and in his specifically Boston, Massachusetts experience. You know, I know exactly what you meant. My last name is Fitzpatrick. But Baltimore City, you know, I think what I've come to realize is there's a significant number of people who are coming to me saying, I don't believe in taking pills. You know, and it's sort of almost like a brag for, I think, a lot of people. And that kind of speaks to the whole thing about folks who want some control about how and what they're taking and wanting to grow their own plants. You know, they think that this is somehow, it is a different model, you know. So there's that piece. And how do I speak to those people and say, well, but you know this, all right, it's a plant, but it is a medicine. And you can take it in a pill form. That doesn't, you know, so you've got to get them to understand that you see it their way, but maybe they need to think about it a little differently too. And then there's the other piece that I think is probably what made me most feel that I'm doing important work with this. You know, it's marijuana, and it's out of pocket. People can't use their insurance. It gets expensive to purchase the product. And all of this in the context of, when I first started seeing patients, it was primarily live people coming in because that's what was required. And these are Baltimore City residents, so many of them, who have limited access to mental health. And beyond that, they even have a hard time acknowledging that they might have something that's a mental health problem. So I spend a lot of time educating people on something like anxiety disorder, you know, and I'm not supposed to be sitting around educating people on anxiety disorder. That's not my job. I'm not getting paid to do that. But these are folks who don't understand that they actually have a condition that needs treatment, and this is a valid treatment. I think we need to recognize that piece as being so directly linked to the whole social justice piece. And where's the social justice if we're charging them so much money for things that they should be able to, in a better place, get for free, you know, if they really need it and it works for them? Yeah. It troubles me because I try really hard to stay on top of the literature that's available, but we're seeing so much of the pushback, on the other hand, from people who are, you know, the cannabis use disorder. I saw an article just recently that was saying there are higher numbers of people developing cannabis use disorder from using cannabis than there are people who are developing opiate disorders from using opiates. And it went on to say that approximately 1/3 of marijuana users develop opiate use disorder, which, you know, that was, wait, what? Have I missed something? Have I been just not paying attention to this topic? And, you know, went back and checked the literature and said, no, it's more like 3 to 8%, and that's still lower than opiate use disorder that develops from being prescribed opiates.
Fair to say that's not an emerging trend, hopefully.
Definitely not an emerging trend. But I think the issue becomes all this stuff that I hear back from other providers. And, you know, let's face it, we hear it. We get challenged on it all the time. And patients who say, well, my doctor thinks this is a terrible idea, you know, and I end up having to say, maybe you might want to consider seeing a different neurologist than this one. You know, I'm not, you because
that's a bit of stigma, right, in systemic, so we'll get to that in a second.
Yeah.
But Dr. Dummer, what are you seeing up in your practice?
I guess, well, one, I got to clarify, I can't write certifications because I'm in industry, but I certainly have overseen, we're over 100,000 patients now and still practice clinical medicine, so I still interact with patients that utilize cannabis on a daily basis. And, again, 7 years, what we started out with really the intractables, and I hate to label patients, and I think it's an unfair label, but it's just true. And I saw one just Wednesday, a woman, severe CRPS, I wouldn't wish that disease on anyone, tried everything under the sun, IVIG, IV ketamine, you name it, every opioid. There's one medicine that works for her, cannabis. And these are the anecdotes that, to be frank, I love them. They've driven me to where I'm at right now, but we're a little bit tired of hearing, because we need to fight for something beyond that. And I am starting to see finally a shift where patients and people are, and this is a movement led by patients, let's not forget that, but more and more ready to come out and share their story. I'm not afraid to say that I use cannabis and I'm Catholic and and I'm an elder. And our fastest growing demographic, many have seen, is over age 65. There's wisdom in that generation. And I do see, related to the lecture, and I'm glad that you hit on this, is just an excitement for high THC. And again, that just calls to question the medical influence on the industry that's moving forward so quickly. And I think it's, education like these and policy where we need to kind of reorient that again, because we're in a phase moving from the intractables to that this isn't your last line, right? This isn't your last resort. And I think many of us in the industry want to push that forward, especially when we've seen so many other prescriptions, and I am not anti-pharmaceutical, but that have so much more harm. And again, just to speak to that point real quick of education, I think there's nearly 20,000 prescriptions that I potentially could write. And one of the biggest things I've seen with cannabis is we hold it to a higher standard, right? In many ways, it needs to lift its standard, but yet it needs to prove itself 100-fold than many of those 20,000 I can write tomorrow. And I honestly don't know all of their mechanism of action.
Interesting. And Dr. Sharma, I think you see 4,000 to 5,000 patients a year, right? You told me.
I mean, over the course of time, I've seen plenty, but I'm a multi-state operation. So I do Virginia, I do Maryland, I do Pennsylvania, and I've seen the prescription process. And some have a prescription process, just like Tish said. Some don't, and you get to see a whole bunch of things. But like in general, I'm going to go back to some nerd data type stuff, okay? So first of all, when you look at kind of how the evolution of what we saw so far over the 5 years I've done this, in the beginning you get your early adopters. It's your whole adoption curve. It's that bell curve where the first group that comes in when you first legalize are the early adopters. They're the ones who think this is holy, this is lettuce, this is the best stuff on earth. I'm here just for this. This is great, doc. And they come in with such excitement and vigor. Then you see the late adopters. These are folks who are like, oh, I heard this really worked for a friend of mine. I'm here to test this out. And I feel like right now we're kind of towards the end of that, and we're starting to approach the late adopters, who are those who are now challenging their religion and challenging their faith and challenging things and going, this helped Bob. Bob can play 3 rounds of golf now. He beat me the last round. I can barely swing a club right now. I need to beat him, and literally we're starting to get into this other phase of adopters that are coming in, and towards the end, we'll see the late phase come up soon, but you go through these populations that come in, and each population has a different way to look at it. So when you said that, Maureen, when you said, hey, the plant, it's a plant. I'm here for the plant. And you're like, yeah, I remember that. I remember a lot of people saying that to me. I don't want any medication. Medications are evil. And I'm like, looking at it, I'm like, but what if you have high blood pressure, you have a stroke? Are you going to adopt medications then? Is that the only time you're going to think, I need a medication, is when I'm about to die? So I've approached a lot of folks with science. I'm a nerd. I'm going to tell you the science the way it is. I hear what you're saying, sir. Sounds great you don't want medication. I hope you're jogging every day, you're eating your vegetables, and you're staying away from all those fatty things we love to eat every day. No bacon for you, okay? And it doesn't always work that way, So, and there was a gentleman up here who said something I really liked about, it's a plant. We should think about it as a plant. The approach should be a little bit different. And everyone in that early adoption phase, they felt that. They were in that bucket. In the late adoption phase, that's where you're absolutely right. These are folks who, they're on medications. They have heart disease. They want to know that they're taking this and it's not going to mess up their ability to treat their cholesterol. It's not going to mess with their liver. It's not going to make their end-stage renal disease on dialysis worse. They're going to puff something on, as a COPDer? No, they're not. They're going to cough and hack, and they're going to have bronchitis, and they're going to be miserable. And so different phases of adoption, different needs, and it's an ever-evolving process. And as a provider, you're challenged. You're challenged to take the person in front of you and lift them up a notch. And that's what you do, Maureen. That's exactly what you're doing. We take what comes, and we realize that we have a broken healthcare system. And when I step outside of my job to do this, it's me trying to repair some of it. And it's Maureen every day repairing some of it. And this is what we do.
Thank you.
I did want to follow up real quick on something with that, because I love data too, and I'm a bit of a geek, and I find it a little interesting too that, and I agree with you on those kind of early and late adopters, but to look at numbers, and it was actually Americans for Safe Access that did this in Minnesota. We're far from kind of late adopters in that, the calculations are that those Minnesotans with chronic pain, 0.13% have access to a medical program. We're not even scratching the surface in terms of accessibility for this, and I think that's just something that we have to be very cognizant of, and I think all the work that we're trying to do here is trying to expand that, but 0.13% have access to, cannabis as a therapeutic that suffer from chronic pain.
Staggering. So what I've heard is there's early adopters, there's late adopters. What I've heard is there's stigma systemically, there's stigma in the doctor's office, there's stigma in our families, there's stigma around. So as in your practice and in your approach, how do you approach the stigma of harm reduction discussion versus therapeutic benefit?
I have a comment to that because we spoke a little bit about that earlier and had one of these moments of like, oh, aha. One of the peers from this organization, our prep for this event, was saying harm reduction, it's so important that we address harm reduction, and became quickly clear that what she was referring to was the harm from marijuana. And I was, what? I'm coming from more of that direct public health experience where getting people to have medical marijuana is the harm reduction act I am involved in. Because otherwise it's kids who are in my neighborhood on the corner getting high, and who knows where they got that. And so when we are out for a walk, I keep cards with me and hand it to these young men, because it's usually young men, I guess. It's always been young men. Are you legal with this? Because if you're not, come and see me, call me. You don't even have to come. You just can, it'll be a phone call and, with a video thing. And they're looking at me like, huh? And then we start to talk. And I'm like, you could get in a lot of trouble for having this on you. I understand that. My own son was arrested 3 times for minor possession prior to all this stuff changing now with people not being arrested for minor possession anymore. But what you go through in these things from back in the day. If they have their medical cards, I know at least they're not going to be consuming something that potentially is contaminated. And they're maybe a little less likely to be arrested. Maybe that's, overly optimistic, but because I live in Baltimore City, I get it. But still, it's maybe slightly less harm we're doing by getting people, and that's a huge thing.
So maybe a little access to safer product, a little less stigma because you have a card.
I had a woman, an older woman, somebody my age, come in and say, well, I decided to do this because I had been buying stuff on the street, and a few months ago I ended up in the hospital for 3 days because whatever it wasn't really just marijuana. And I've had a number of those situations where people come to me and say, I got sick, or this made me worse, and I'm afraid to use this as our way to do it. It's not going to cause that again. The patient who has really bad anxiety disorder, and somebody gave them something very potent, and now they're having a panic attack from the marijuana. They don't understand. Well, yeah, plus your heart rate's up because you were using some marijuana and you're particularly smoking it. And they don't, so thankfully they're coming to us. That's the harm reduction for me.
Great, thank you. Yeah. Dr. Dahmer?
You know, I'm a huge fan of harm reduction, and just really support it in any means by which I can. My clinical hat is, you know, I meet very few patients that get excited about harm reduction. So, you know, again, I really like to lead with, like, what's the potential benefit? I mean, this is, if you're going to get buy-in, there has to be, you know, this is going to, and I think coming back to Dr. Tischler's point, I'm not pro-cannabis, I'm pro-patient, right? So how is this truly going to help you? And there might be a subset of that is harm reduction. But in my experience, you always have to lead with, this is how this potentially could help you in this dose, and this is what we're going to, and as a side effect, I'd love for you to be Kelly sober and get off alcohol, or fill in the blank, right, of that harm reduction. But I think that we really have to, you know, kind of, I hesitate to say celebrate, but, you know, really encourage the plant for potential benefits, and that's why we're utilizing it, as opposed to that harm reduction approach, even though I'm such a fan. And I think policy is a different argument, right, in other areas, but with the patient in front of me, it's generally, this will benefit you, I hope, for this reason.
Excellent, thank you.
So, I mean, I'll chime in as well, but we're all in agreement up here that, you know, we think this is part of harm reduction, but there are incidences where things can go wrong. If in industry and in an unregulated new, it's when you put up that picture of the bottle, and I'm like, in my head I'm laughing, I'm like, that's where we are now, you know? We have an unregulated industry. We have an industry that if you get the rec folks from California to run, they'll drive THC volume like you wouldn't believe. And have I seen areas where I had to do risk and harm reduction? The answer is yes. And it's with my elderly patients mostly, and with children. And so, you know, when I'll fuzz out her name, we'll call her Gertrude. When Gertrude called me up from Pennsylvania, and Pennsylvania launched their program aggressively, like, we're going to build this program, it's going to be great. And then the first thing they gave out was oil. And the oil had a 70% THC value. And Grandma's trying to use this for sleep, and she tells me, hey, Doc, I have the wildest dreams. And it's just, it makes me uncomfortable. I don't know if this is the way I'm supposed to use it or if something's wrong. I'm like, show me the bottle. And she puts a bottle on the little camera thing, and I'm looking at it going, 75%? You're on a rocket, my lady. This isn't the right way to go. And we had to, and I was fortunate her son was there, and we're talking about how to reduce that percentage by the addition of CBD and how to get a safe dosage out of it. I'm like, 25 milligrams? No! And if you let industry drive it, that's what's going to happen. You're going to sell your most valuable product in the office. And unfortunately, stuff with higher levels of THC is more valuable to sell than stuff that doesn't. So a lot of the patients that I run into in the Pennsylvania corridor, I'm always like, hey, wait a minute. Let's go over how to mitigate some of that extra THC. We're fortunate now that that word finally got out to people producing, and the stuff that's out there is a little more friendly. But the same thing did exist in the Maryland market. And we saw it in terms of inpatient admissions to hospitals. And you can look this up. Cannabis inpatient admissions age 60 plus. And you will find that it would have been a group of well-intentioned young folks who are like, Grandma, you're having trouble sleeping. And they pull out the little, it'll go brandless, gummy troche, 50 to 100 milligrams.
Yes.
And we've all seen those. And your advice and my advice would have been the same. Don't take the whole thing. It is a mistake. 50 milligrams, that's 3 days of wobbliness. You don't need, Grandma. That walker is not going to be enough. You know? And did it happen? The answer is yes. It did happen. And it happened with such a frequency that the state actually went back and reformulated all the stuff we have to 5 to 10 milligrams, which I was like,
Yes.
5 to 10 milligrams is great. 50 to 100, potentially dangerous, you know? Then you have the, you mentioned RSO, that little stick of glue can be a potential source of harm if you don't realize you just need a pellet. And with that, you know, I'll end with a little bit of joke. At the same time that all these people were making mistakes, I did have a genius, Gertrude, who came up to me and said, "Hey, doc, you know, I make my own edibles." I'm like, "What do you mean? You process, you do the whole, you know, running it down and filtering it out and all that?" She's like, "No, doc, that would be too much work. You're thinking too hard." I was like, "Okay, what do you mean?" She's like, "All I need is a little bit of RSO and a Swedish fish." I put a little drop in there. I can know exactly how much to put in there, and I got my medication. And I'm like, "You didn't have to process or do anything?" "No." And she's like, "If they have oil, I know exactly the amount of oil to put in my gummy bear." I'm like, "Oh my God, this lady's a genius, and we should spread this like gospel, you know." But harm reduction comes down to the fact that there are folks who are not going to react to dosages of this stuff the way we want, and it's the truth, right? So folks with anxiety will hide under the table if you give them a high dose of THC and they feel their heart beating and they feel they're sweating and they know that something's going on and they can't figure it out. It's just a little bit of a high, man. Just calm down. Glass of water. No, for that guy, it's an experience. He's under the table. His back pain's better, but he's calling me. "Hey, doc, you know, I don't know why, but I think there's someone at my front door."
He
like,
thinks he's going to die.
Yeah, he thinks he's going to.
He's sure of it.
True stories. So our elderly patients need guidance. Our patients with specific psychiatric disorders will need some guidance. You know, someone with bipolar shouldn't think that this is going to solve their problems. This is not the right answer. Folks with major depressive disorder, this isn't going to get rid of your suicidality at all. It has very weak SSRI effects, period. And that's what most of the studies suggested over time. You can't use this as a treatment for depression. It does not work. And a lot of folks come to me, they go, "You know, I have depression. I think that's why I should get this." I'm like, "Tell me about your back pain."
Yeah, we just wanted to follow. Sorry.
No, go ahead.
No, I wanted to follow that. Again, one more thing with data, and I find it very interesting. So in Minnesota, we do have and have had for 7 years post-market surveillance, so pharmacovigilance data. And despite, you know, vaporization, in the beginning, Minnesota was an oil-only state as well, so there wasn't flower. Despite vaporization being the highest seller, it was our oral form, believe it or not, that had the highest number of hits on adverse events. And one thing that we don't talk enough about, I actually love the Swedish fish story, is we did work with Dr. Angela Birnbaum at the University of Minnesota, and depending on whether you consumed your cannabis with a high-fat meal or not, you had 5x the median dose, right? Five times based on whether you had fat in your stomach or not. And you know, again, these are subtleties. We're not even getting to that third layer yet. But very important things from that medical perspective that we're talking about and educating when patients are consuming, not just timing and delivery form, but even what else they're consuming that with and that it's consistent.
Great, thank you. So let's move into maybe perhaps more about the patient and what you may be seeing in your day-to-day practice. Jackie and I, and perhaps many of you last week, were at the Cannabis Science Conference, and we learned quite a bit about the research and approach to fractionating the compounds and beginning to look at the cannabinoids, the different mechanisms of action. Very interesting stuff, a lot of stuff that I was excited about hearing coming out of Israel. I'd like to see more here. But in terms of what you're seeing, let's talk about perhaps patient condition, the top conditions you're seeing. Are there new products or formulations? You've heard things with CBN, CBG, the CBGA, CBDA. Are you at that level where you're hearing that? Are they requesting that? I'd like to find out what the trends are, what either you're referring them to or seeing them request.
I'll jump in and just to say that I think I maybe fall along the lines of Dr. Tisch a little bit more on this one as well. And I think I've practiced integrative medicine for over 20 years. And so I see a lot of hype come and go. And I don't want to call it all hype, but I'm really on the fence. It's constantly, I see a new cannabinoids, that's the excitement. And I'm enthralled with it. And I'm passionate and very interested in it. And I'm also a biophiliac. which means that I love nature. We have this plant that we don't understand yet, and that we're running after a minor cannabinoid and maximizing the dose. And why can't we just work even with what's there and understand it better? And so we play that game, and certainly CBN and CBG, and wow, there is some very fascinating research, and glioblastoma, even some fascinating research with minor cannabinoids. But it's really, in my mind right now, a fair amount of hype, and I won't turn a patient necessarily away from that, but let's focus on those that have a little bit more research, and that, for the most part, is directed at major cannabinoids and ratios of that.
I saw recently a comment in the literature that was saying there's really nothing to back up the claim about CBN really helping with sleep. That we don't have, and I never thought about it, it's what everyone says. So that's part of the problem for me too, as much as I tried to read, we don't have enough to go on.
Do you guys remember the migraine study by Tilray, Canada? So there was this nice little comprehensive study. They were trying to, their industry, Tilray's big industry, right? That's big cannabis. That's not mom and pop cannabis. That's metric tons of cannabis. And they're trying to figure out, hey, we're going to survey our patients on just migraines. But we want to know, is there a specific strain type? Is there a specific pattern to what people like? And they did this study, and they got, I forgot how many thousands of patients into it. And the conclusion really was, it was fun. There is no rhyme or reason. There is no one specific way to treat it. People were spread across like a bell curve of cannabis. There was some sativa, there was some indica, there were in between. There was no rhyme or reason why it should have helped everyone in that way. And I feel like I'm a classical doc in some respects. When I heard the CBN hype, I thought it was hype. I was like, okay. So I started asking my patients, hey, you took CBN for sleep. How did it go? And I would get the same story. Oh, I had these wild dreams. It was on the, and I'm like, so show me the bottle. And sometimes the filtration and methods that are used are not perfect. So what happened is a lot of folks were getting these CBN concentrates, but out comes with it THC. And it's just part of one of the flaws of the biochemistry of it. So you can't fractionate everything out cleanly. When they make a CO2 extractor, and at the end they have 3 bottles. One's like terpenes, one's CBD, one's THC. And then they start reformulating. I mean, we're playing with fire because we really don't know the answer of what is the right combination of this. We don't have the data. We don't know where we're going with it. So I tend to say, hey, look, the flower is great. I love the flower. You could predict the flower, but I can't predict the chemical makeup of what's going to happen. But I know a lot of THC for your sleep is not going to help you sleep. I know a lot of THC for your anxiety is not going to help your anxiety. So I think we're at a point where without clear research and without clear guidance, we are not going to be in a position to say, these are the cannabinoids you should use for these disorders and diseases yet. And where does my doubt come from? I was an undergrad at the time, University of California, Berkeley. I was sitting in Wheeler Hall, the largest hall we had. And I was right there in the middle, and it was a medical lecture about cannabis. The oldest cannabis club in the area was in Oakland, California. And the guy came down to talk about all the things you could cure with cannabis. And he puts up this slide of 400 diagnoses. And he's like, you could cure it all with cannabis. And I'm like, really? How? And the truth is, it probably has some effect to all these disorders and diseases. We can make hypotheses as scientists on what's helping what, but we don't have the hard data to make any claims whatsoever. And I don't think it's right to make claims in this area. We can suggest based on what we know works best for each diagnosed age group, but I'm not going to be able to say, that gummy by X, Y, and Z company, that 3-to-1, oh my God, that is the miracle drug for sleep. I cannot do that, and I will not support that amongst our community until we have data. We can't do that. So
what level of guidance do you give then when someone comes in perhaps with the chronic pain or you find a diagnosis?
I'll go back to Tish's statement that we should have a prescription, all right? There are basics that you want your patient to know when making an informed decision, right? So when someone comes to me and they have no clue about cannabis, I've never touched this. I don't even know this. They said this is bad stuff. I will spend more time with that person going over how is it organized in the dispensary? How do you test this out? What is a safe way to dose this? What can you adjust based on the medical market? And so it's not going to look like CBN and CBG and all this other stuff. It's going to be your basics. THC and CBD are your prime oils. Those are two you can increase or decrease based on what you're treating. You have 3 base categories. And there's variance in there. That one that's called hybrid has a big question mark in my head because every single patient gives me a different description. I'm like, you like hybrids with your lupus? Tell me, what do you feel? Why is that your go-to? I'll hear stuff like, it felt like an ohm. It felt like, aha. It felt like I feel normal. I'm like, what's normal? I don't know what normal is. So I will give base guidance, almost like a prescription, but the goal is to, this naive to cannabis industry person is going to walk into a dispensary with 300 choices, and I don't want you to get pigeon-tailed into a spinning wheel at, oh, look, we have a sale on 80% THC cards this week, and I know where that's going to end up, and I don't want you to be there. I don't want the call from your wife in the middle of the day that says, he passed out in his cereal. I saw your name on his vape pen and your phone number to your office. So I'm calling you to ask you, how dare you give him this stuff? Like, that's not what I'm aiming for. So base guidance would be, this is how you can pick and choose. This is how you can adjust. This is how you can dose safely. And this is how I want you to approach this like a scientist, not like back in college. You know?
Steve, I want to sit on that for 1 second. One, I do want to mention that we have an ongoing clinical trial, randomized double-blind clinical trial right now that has our red 4.75 milligrams THC versus our green, which is 2.5 milligrams versus a CBD, basically 0 THC versus placebo. And then we have a standardized dosing schedule, basically 1 soft gel before you go to bed based on your adverse events and how your pain is doing. So let's ask this question in 2 years. And I want to kind of transition from that I think the elephant in the room here too is that what we don't talk about in medicine a lot of times is this science-practice gap. And there are some estimates that it takes 15 years for science to be actually converted to practice. And so we're in this gray area that we're never going to have clear guidance for what is essentially 500 plus drugs in a single plant.
You're on the frontier of medicine.
She is, you know, and we have to make our best guesses. That comes back to probably one of the most important things, and that is this, medicine in general is a movement towards personalized medicine. And that means that's a great study for the 55-year-old white guy, you know, but that patient in front of me is responding to this product they may have gotten on their own, and I can guide that better to ensure that, or to do my best that there is a positive outcome for them.
We also have to talk about, and the current state of medicine, the one thing we saw in the pandemic that still rings in my ears is healthcare inequities. And we're not going to be able to fix it in you know, all these little spaces. We have to fix it as a whole country. But, you know, in the research space, there are healthcare inequities. We see that when I prescribe blood pressure medications. There are folks who respond better than others to the standard medications. And we're probably going to have to expand our thoughts with research on many fronts and in every field to get this right. You know, the old cardiology research was on 55-year-old white men. And when it comes to women and blood pressure response, African-American males and blood pressure response, it's a different set of medications. That came out of Emory University several years ago. And I'm like, why doesn't everyone know this? It's because we have to get beyond these inequities and these areas and just push. And it's a constant battle. And the fact that you're looking at that, I appreciate that. But we all have to.
Yep. Great. So what I've heard, there's a gap, right? We're going to get to questions in a second, okay? We're going to need the microphone, so we'll get to the question. Please hold that. And we're almost there. So what I do want to address, though, is there's gaps everywhere in this industry, right? And you had mentioned this science practice gap, which is new, and I really appreciate learning about that. The gap of data, the gap of research, we can't wait for all of these studies to come out. So what I'm wondering is do you have patients? I come from the fintech space, and technology is really key. And what I love is that there's companies filling the gap right now of data, right? They're giving this tool to patients to track what they're taking and their interactions. And while it's not scientific yet, I think it's really valuable, right? And so are you seeing that? We've got a lot of tools that are out there. What's your thought on at least having that level of data? While it's not a random, controlled RCT, it certainly is something.
Do you realize that during the COVID pandemic, it was the 23andMe folks that helped push us forward?
You're welcome.
You're the best. So the 23andMe folks, gave us a subset of data on who was falling out and went back to blood type and genetics. And it was fascinating. It helped push us a little further than where we started. Technology is not the enemy. It's raw data, but it's unfiltered data. And that's where we have trouble in this current modern world. We have unfiltered data flying everywhere. And so until something is randomized and controlled, like a proper study, we're making assumptions based on what could be faulty information. Faulty information, as we know for the last couple years, can really lead us down a rabbit hole of stuff. And we can't afford to spend healthcare dollars and budget and bankrupt people over things that aren't true. And so my personal thoughts, for the last 5 years, everyone I've seen is like a science experiment. And I've carefully kept a log of who responded to what, and that's what guides me to where I prescribe and what I recommend. Some of that is based on certain studies that were done at the Lambert School of Cannabis in Philly and certain other CME-based programs, which were very useful. But for the most part, I can tell what helps over time because of the large subset of patients that I'm like, okay, out of this group, this was a failure. We should not do this. Out of this group, these 12 people did really well with this subset of therapy. We need to guide more people there. Maybe we'll see a better result. And each year I track.
Excellent.
And so until I have trials on my own, that scientific mindset, the same mindset that guided me to write protocols for COVID at a community hospital, same thing that's going to guide me, help get people the right answer. It's that base science that we all should not forget. And that critical nature that we need to question everything. When we stop questioning and we start believing blindly, some people may take bleach for that solution.
Yeah, yes, exclamation point would be my answer to that. And, again, in the midst of a randomized double-blind control trial, if we pull off the impossible, and it is near impossible to conduct research on products in the market right now, but if we pull that off, there'll be criticisms. How do you placebo blind a psychoactive substance? So even then, that's not going to give us that answer. So you need to augment that. We just wrapped up in conjunction with Montefiore a longitudinal observational trial. So naturalistic, people with chronic pain in the New York program take whatever they want, 18 months followed, validated measures along the entire path. What comes out on the other end? Who did well? Who decreased their opioids? Use that to augment an RCT and, love databases and probably had 5 conversations. And Otha's going to speak later. And we have tetragram in our dispensaries because that will augment these other data sets getting to the point where how do we support that patient? I love to say, how do we support a patient in creating a good relationship with the plant? And it's going to need all of these disparate data sets, including post-market surveillance, for us to get to that resemblance of a kernel of truth or to be able to personalize it for that person in front of us that might be different for you or for you or for you.
Excellent. Thank you. Great. Well, how about a round of applause to this great panel? But it wouldn't be finished if we couldn't let you ask some questions. So I know someone back there. Yes, we're going to give you the first opportunity. We're just going to give you a microphone if we can, Jackie. I want to make sure that everyone at home can hear these questions and answers.
Hi, thank you very much. My question again is about teaching your patients to track their medicine for themselves, because it's great that you can tell based on this and that, but I think it's more important for the patient to be able to tell. I myself, medical cannabis patient, and I know that when I go to my gastroenterologist and he rolls my eyes at me about the cannabis stuff, I can then, basically, because I track my medicine, show him how I've tracked it. So I think it's very important for doctors and physicians to make sure that their patients understand how to track and that they have available to them the information and the studies so they can make their own decisions. Because my dad was a doctor. I mean, back then medicine was, this is what you did, period. And you followed exactly what your doctor does. But I know for myself that I can tell better because I know what it means when I say, I feel really good. And the doctor's saying, well, what does that mean? Well, it means I feel better than I felt before. And sometimes it's as much quantification as you're going to get. But if you teach your patients to track and using the apps, because there's some fabulous apps out there, they're going to be a better partner with you in their self-medicating.
I can't agree with that any more than I can 100% agree with that. But I'll take it one step further. Just think beyond cannabis for a sec. Every medication we prescribe, we should be training people on how to monitor. You're on blood pressure medication. What's your blood pressure for the last week? Are you taking it regularly? When do you take it? And are you reporting that to your doc when you see them? Same is true for diabetes. Same is true for heart disease. All these things are supposed to be tracked, but not everyone is equipped with the know-how of that. And to teach and educate and to grow that, we all have to take that on. I'm always like, Dad. My dad's a tricky guy. He's not an ordinary diabetic. Maureen, I don't know if your dad does this, but when we used to come to his house for vacation, my mom would buy a bunch of sweets. And he would intentionally know that they were down there. So while we're watching TV, because we're a little jet lagged, he would come down the stairs to eat a bunch of sweets. But I would be like, Dad, you can't do that. You're a diabetic. What are you doing? Are you crazy? And he's like, son, I got this. I'm like, what do you mean you got this? I'm going to take double my metformin and X amount of this tomorrow, and I'll be absolutely fine. Now, the thing is, he's done this experiment before. He's been tracking this, and he did it because his sugar was below 150, and I was about to pull his hair a little bit. I mean, like, Dad, what are you doing? You're going to kill me. But he was right, and all patients should have that capability. And we should be empowering people with heart failure to understand what Lasix does. We should be empowering people to understand what long-acting insulin and short-acting insulin does. And people should know how to adjust. As docs, we have a hard time telling our patient to titrate medication because we're used to the old school, which is, this is your dose, why did you stray away from it? And that might not be the right answer for everybody. And it's not the right answer for everybody. So I completely agree with you. But the way to do it and the evolution of that, in terms of modernizing medicine and this healthcare industry, is going to take more than just us here. We have to do this with everything.
There's so few patients we do that with on a routine basis regardless. I love it when I meet a type 1 diabetic who was taught to carb count. Or somebody, and sadly, somebody with seizure disorder or migraines who is taught to count the events and keep track so they can report back. But that's a good example of migraineurs. I know I'm succeeding when they come back for renewal a year later, and I ask them, how many migraines are you having per month or whatever, pick the time, and because I got the data when I met them the first time, if I met them the first time, and they're a renewal for me, I know what they were having before, and now I know what they're having now, and we can compare and talk about it with each other. But medicine, we don't normally empower people in that way. I mean, there's patients who don't want to know. They don't want to think about it. But I think more often than not, they do want to have some idea of what's happening.
Think about the technological upgrade we've had all across, right? You can track your blood pressure and you can put it into your phone, it will log it. You could do that with glucose monitors. We didn't have that before. It was paper. Remember those little paper books people would come in with? And you're like, wow, their writing is as good as mine. Like, is that 130 or 355? I don't know. But we've come a long way, and we have to evolve and adapt. And the fact that we do have an app out there, people can report, it's great. People should use that. We should have preliminary data to work with. How do we apply that? How do we do it in a safe manner? How do we not jump the gun, though, and draw conclusions which are going to hurt people? This is a miracle. Use this. No.
I think in medicine we do it as well, but it's usually based on an objective measure. So I'll routinely do that with a diabetic on a long-acting insulin at night. They don't need to call me to go from 25 to 26 if their blood sugar is still 325, and they shouldn't have to. But the trouble with a lot of the diseases that we're treating or that we're working with in cannabis is that it's a little nebulous, right? Chronic pain, we have scales. And Sarah, I'd be very curious in terms of how you rate that yourself when you go back to your doctor. And just one more point, I think what we've really seen in research lately is looking at quality of life. And I've interacted with hundreds, if not thousands, of patients with chronic pain using cannabis. It's rare. I hear them say my pain went from an 8 to a 2. My relationship with the pain is different. And so we also need to know from what angle are we measuring that that's going to make sense for the patient on the other end. And quality of life is a big one that I've been scouring the validated measures of quality of life and which one works best. And they're usually about 30 questions that most patients aren't going to do. And in my own practice, I ask every patient, tell me your health 0 to 100 today. It's not validated. But it just gives you that time to reflect. I'm a 79, right? Or I'm a 39. And also that reflection 6 weeks later of, wow, I was at a 22 and I'm at a 35. And it might not be validated. But anyway, Sarah, I'd love to hear how you measure that.
Yeah. Thank you. I measure it by, because I have neuropathy, is from chemo-induced neuropathy. And so I measure it by how much my feet and my legs tingle previously, how difficult it was to possibly walk previously, and then in a combination of one-to-one topicals as well as an additional topical from a 350 milligram CBD, as well as some inhalation. That goes back to, I can go down and do yoga. I can, go to the gym and work out on weights. And be relatively pain-free. When I go to Europe, that's a completely different ball of wax. I take no over-the-counter pain medications at all. I don't take any gabapentin, none of that. It's all strictly cannabis.
Great, thanks.
Does that help?
Absolutely. No, I love it. Quality of life, it sounds like to me, just to be frank.
Definitely, yes, on the tracking your medicine. I personally kept a tasting journal the first year that I was a medical patient here. But also that kind of brings me to my question. So I'm an attorney here in Maryland. I am a medical patient here in Maryland. And after I finished law school, I spent some time as a bud tender. And we talk about providers, we talk about patients, but there's a link in between providers and patients in getting this medicine, and those are dispensary workers. There's really no kind of standardized training or expected kind of knowledge that comes along with that. So my question to you all is, what would you have dispensary workers know so that they could pass that on to patients in a more helpful manner?
I have a list for you. It's already ready. I don't have it with me, but it's, oh my gosh. It's at my office.
We also are in the process of accreditation for that, and we did work with, and not to just name names because there are 100 great names out there, but Green Flower has created very formalized training, and I think we're going to see a ton more of this, that this is the standardized training across the board. And we obviously have been deeply involved in our dispensaries and mainly overseen by pharmacists, which is very helpful, but there will be a baseline that has a list of educational topics that need to be followed. But I also, again, it's like, I've recommended supplements for 20 years, and I don't tell my patients to go to the health food store and ask them for advice there. I say, here's the supplement I want you to take. This is the product I like. This is their COA, and here's the dose that you're going to take. Like, we don't need to reinvent the wheel here, and it's something that many providers, healthcare providers, have done forever. And you know what the products are that you trust and where they come from and what they don't have in there, and you know what the patient should be taking based on your own expert opinion. Well, I don't believe in experts, but in your professional opinion.
One more question.
Anesthesia interventional pain management here. I'm happy to hear and excited about the potential of cannabis as medicine for opioid reduction, as well as how you mentioned harm reduction as a harm reduction tool. Can you speak on what you suggest, or how do we get other physicians, our colleagues, involved in this conversation?
This is a hard thing to do. I mean, I've had open doors for lots of providers for the last 5 years. I've held talks, I've invited folks. But over time, a lot of the folks who now refer patients to me come from that pool of people that we had to educate painstakingly. But I want to back up for a sec. Pain, and the way we think about pain, philosophically and anatomically and physiologic, has some flaws as a doc. Our normal response when someone comes in with chronic pain, and you know, if you're in your office, you're like, I got 5 minutes. This is what we're going to do. We got my muscle relaxant, we got my NSAID, and then my referral to the specialist. You know, but we're missing a lot of conceptual ideas and notions out there. The pain pathway doesn't just go through from I broke my finger to my somatosensory area, and it's done. It comes up the spinal cord. There are modifying nerves that go with that, as well as you go through the frontal cortex, the limbic system, then the somatosensory cortex. And the effective parts we are missing as clinicians is social and emotional harm of chronic pain. We're good at addressing the actual pain, but we're not good at talking about the other two modalities that treat and that are part of the process. And because of that, I think we've caused some harm. We go for the shortcut, but the real answer is, how do we address the fact that there's an emotional scar from this and there's a social scar from this that you're carrying, and how do you get over that and manage your pain better? I've seen folks use cannabis to modify their emotional and social state, and I saw their pain suddenly go away. And I was like, this is amazing. Maybe it's not the pain receptor I should aim for, maybe it's the brain. Maybe there's something else we can address that can help modify the way things go. So there was like I said, I heard this great talk once. It was Rachel, I want to say Zolfness or something of that nature. And she spoke about cognitive pain therapy. And that all these medications we're throwing, at the end of the day, if you have chronic pain, your pain fibers are supersized, they're muscular, they're going to shoot pain if you just scratch the area. And you could try this on your patient. Don't do it every time. It's not going to be fun. But if they have back pain and you kind of rub an area and they're past injury and they have the same pain again, it's not that you've thrown enough medications or you need to throw medications. They have a pathway that's supersized. It's working super fast. We're not thinking about pain the way we should. That chronic pain patient is very sensitive to anything touching that area. Cold, hot, scratch, wind, you know. I bumped it. Oh, I got it again. I can't move my leg. No. You have no injury. The MRI shows you're fine. The CT shows you're fine. You know, EMG studies show you're fine. We could do all these studies, right? But why is that happening? Addressing that's a lot harder. So as a clinician working with these folks that come in, I'm like, hey, have you thought of, have you worked through, what about this? I just want to be there to ask the question and then provide the extra support with some medication. So.
Excellent, thank you. Okay, we have one more question
from the chat and then a comment.
from the Zoomiverse. Yep.
So this is sort of addressed to all of you, to the entire panel, in regards to your views on real-world data and real-world evidence. It says the FDA has provided opinions and guidelines, but I want to hear from these experts on the value of these studies in the current world with focus on what are the key elements of design.
So,
What was the question? I'm back in high school again. I'm sorry. What was the question?
I think it's asking for the way that you interpret the FDA opinions and guidelines versus your real world data in terms of working with your own patients?
We don't have guidelines. So, you know, that's, I'm sorry. But we don't really have guidelines. That's
The
the
NIH
biggest issue.
has a page, but
you
it
know?
doesn't have guidelines.
Yeah.
It has kind of these are the receptors we're studying, these are the notions we have now, but it doesn't have a dosage guideline, it doesn't have a strain guideline, it doesn't have a,
We're sort of having to wing it.
you're on the frontier of
I
medicine,
know you
Maureen.
keep saying that, but I just don't.
I'd like to speak to it a little bit in that, again, real-world evidence is a catchphrase right now, and everyone's very excited about it. And, in the big picture, seems very interested, and I'm very fascinated with it myself. The problem is that when you have these disparate, huge data sets, can you drill down to, something that's actionable or truly insightful? And if you look at the FDA process for real-world evidence or real-world data, you actually have to file, an IND, which is a very exacted protocol on how you're going to capture that evidence and how that will be utilized on the other end. And that's the challenge that we have right now, in that so many disparate data sets with 1,000 different products on the market with many different delivery forms, is there going to be an output on the other end that could be actually insightful? And so that's the question, that's what I hear, is how can you set that up on the front end that something other than gobbledygook, right, GIGO, garbage in, garbage out, comes out on the other end? And that's where those creating these databases, and the buzzword right now is registry, and there is an RFA by the government for a registry right now. Those registries have to be exacted in capturing the data, and even spoke with a lab today. How do we know exactly what's in a product, which we're not talking about enough? And then what are those measures that make sense that we're going to be actually asking patients throughout the process that will give some insight on the other end? And this is a really tough quandary, because again, just to speak 1 second more, you have just patients getting tired of answering 50 questions and the need for hundreds of thousands of patients to contribute their data. And this is the real challenge. I think it's a true avenue by which we will infer insights in the future, but there's a lot of thought that has to go into it, and there's not a quick answer to it.
Thank you. Okay, one more. Hi, I have just a comment I'd like to make. I'm a registered nurse, and I have a company, we staff for specialty IV drug infusions, prescription drug infusions. So we work with a lot of people who are chronically ill, neurological problems, patients, primary immune deficiencies. We can offer guidance and suggestions, as I often do for people who have intractable chronic pain, to go back to their prescriber to discuss possibly using cannabis as an adjunct to what it is they're using prescription drug-wise. But what's really missed here, not just in our discussion, but overall in the medical community, are people who are using and self-medicating with cannabis, who have undiagnosed and untreated mental health issues, serious issues. ADHD, ADD, people who are on the spectrum. We see quite a few of those patients. I have people come to me off the record, often asking or telling me, I'm drinking a hard seltzer, I'm having a shot of vodka, and I'm taking edibles. What should I do? And I tell them, I can only suggest to you what I would normally suggest to my patients: go low and go slow. If you're vaping, if you're smoking, if you're using edibles, people do find relief. But what they're not finding is, if they don't have medical insurance, they're not able to afford the visit to the nurse practitioner, to the prescriber, but they can afford to go to the dispensary where they can get adult use cannabis. So I think it behooves all of us just to be mindful that there are many people out there using cannabis, not just recreationally, but they are medicating themselves. And so I find it necessary to tell people, use it responsibly, if that is such a thing. And I do believe it is. Use it responsibly, because it does help people. But because we don't have enough mental health specialists and we don't have enough outreach, people are putting their hands on what they can get. And I prefer that they go to the dispensary than getting it from their friend Boo Boo on the corner, because we don't know where that came from. We don't know how it was grown. But I can say to you, if you do have a gummy and it's got 10 milligrams, try a quarter and see if that works for you. Give it an hour, hour and a half to work. If that doesn't work, take another quarter, okay? But just, again, low and slow. But that is a real issue that you all see. We all have seen people use cannabis outside of what it's really meant for.
So it's so wonderful to hear that these people feel comfortable telling you this and sharing with you, because, you know, that's the other feature, is the fact that they mostly feel ashamed of it. They don't want to admit to it because they know they're going to get judged. And it's constant, you know, and those negative judgments are stopping patients from telling us what's really going on. Even the ones of us who are, I'm not going to judge you that way. Tell me what's really going on. They're too used to that negative. Yeah.
Great. Well, thank you. Again, applause for our panel. And I would now add, not only is this the clinical and scientific use, but the practical use of medical cannabis. So it's great discussion. Thank you so much. We're going to take a lunch break now. We have some sandwiches and food in the other room. If we can be back here at 1 o'clock, we'll continue on. All right? Thank you. And those of you at home, network, we'll be back in 30.